in July,
Yes.
ESCA journal. What's the difference between conventional or regular microfracture and your technique?
So
Very shortly, because
yes, very short.
Yeah.
The difference is now we have now always the same size when we do the nanofracture. Before we do microfracturing, everyone do it in different ways. So the depth is different, the size of the condo pick is different. And what we are doing now, we have always the same size, it's 1 millimeter diameter, and it's only 9 millimeter in the depth. So when you use these, you always go 9 millimeter and 1 in the diameter. And it's a great honor for me that you already present some data, so thank you very much.
Okay, thank you so much once again. Martin, sorry, Alberto. What's your opinion about do you have any new technique for microfracture? Because you are one of the international experts. We know very well known name, Alberto Gordo. Very short, please, Alberto.
There are nothing new about microfracture. I think there's interesting study here showing that maybe micro drilling can be, but at the moment it's still experimental. So no new techniques on microfracture. But regarding the use of YALOFAS, that we have a long time experience because we started with this scaffold in 1998. At that time was seeded with cells. Now we are using without cells. I would recommend to pay attention to the size of the lesion and to put the scaffold very carefully inside the lesion, because I saw some picture, and when the scaffold is not completely flat, there is a possibility to detach. And normally we don't use 2 layers, but only 1 layer. But if there is a deep lesion, it's good to put the bone marrow underneath, like the sandwich technique, and then you can cover it.
Wonderful, thank you, grazie mille. As I told you before, the depth of the crater is the other important point. If more than 1 centimeter, we have to add something like allograft or autograft first, then after HyaloFast. Thank you. Do you have any comment on this? Okay, thank you. Thank you, Loretti, please. Any other remarks or questions from the auditorium? No, thank you. Charles, do you have any recommendation? Yeah. No. Okay, Carla. No, nothing. Because I would like to hear something from the industry. In the international meeting, impossible to get the news from the industry, only in the brochure. You are here. Okay. Next speaker, thank you. Next speaker room. Any other? Okay. Okay, fabulous. Wait. Very great pleasure.
Are you using fibrin glue to keep the membrane sealed or not?
Good question.
Both of them.
At the same time, synchronized or
Yeah.
step by step?
No, synchronized.
Okay. The same.
I use fibrin glue in the ankle when the osteochondral lesion is close to the side and I'm not sure that it's well shouldered. I put fibrin glue, yes.
And in the knee?
Not so open if the lesion is well shouldered. If it is close to the trochanter, yes. Because I want to have good surrounding good tissue. If one side is maybe not quite covered, I prefer to.
Your opinion, Manuel?
Dr. Sciaretta is one of the experts in cartilage. Please, once again, your advertisement first, I think, Fabio. Okay, I never use fibrin glue or T-cell in the ankle. I use only for patella. On the other side, for the knee joint, I locked knee brace for 3 days. Then after, left alone. Okay, thank you. Thank you. Another question? Yes, please.
Okay, good morning to everyone. I want to thank Seneca Therapeutics for this opportunity. So my talk is focused on condyle defect reconstruction with hyaluronic acid scaffold and mesenchymal stem cells derived from autologous bone marrow aspirate concentrate. As all we know, articular cartilage has a limited regeneration capacity, and this capacity is due to the infiltration of the mesenchymal stem cells from the bone marrow through perforations of the subchondral bone And unfortunately, the tissue, as we have just seen before, is the reproductive tissue is weak, and it can have a breakdown, especially in young, active, and competitive patients. So, according with the literature, to produce cartilage of better quality, we have to create favorable conditions for the mesenchymal stem cells. Therapeutic goals still today are to resolve the symptoms, ensure functional recovery, restore the integrity of the articular surface, and prevent further degeneration. But to ensure this, we have to create a tissue that has the mechanical properties of the original hyaline cartilage. So in our hands, the treatment procedures are a lot till today. And we can have symptomatic procedures, repair procedures, regenerative procedures, but each one of these has some tricks, such as neurocyte morbidity or the possibility to have a weak tissue as a repair, and the high costs of, for example, of the autologous chondrocyte transplantation. So the necessity to have a good quality tissue and a good compliance of the patient with less expense introduced today the possibility to do a new technique with one-step mesenchymal stem cells implant with scaffolds. So we have two regenerative techniques, and fortunately for the second one, like this review, recent review say to us, there aren't randomized trials, clinical trials in the literature, but only level 1 preclinical studies. So we have not yet the results of this technique. Even if the good clinical results of the MICI transplant of chondrocyte are very good, and this is so well known in the literature, but there are some disadvantages. 2 surgeries, high costs, and graft not immediately available. Otherwise, the one-step techniques with scaffold and mesenchymal stem cells allow us to restore both cartilage and subchondral bone tissue, avoids the 2-step surgical procedures, and we can collect the cells from the bone marrow directly with subchondral bone drilling, or from the bone marrow aspirate from the iliac crest. But there is a limitation. The mesenchymal stem cells cannot be used free in the joint. In fact, some papers found only a small number of mesenchymal stem cells in the implant site after 10 days. So this means that the mesenchymal stem cells need a scaffold for support to stay attached and grow at the defect site and to build a 3-dimensional structure of hyaline-like tissue. So, therefore, the goal is identifying the appropriate scaffold. Which is the ideal scaffold? It should be resistant for arthroscopic implant, 3-dimensional, absorbing, allowing good cellular adhesion, enhancing the mesenchymal stem cell proliferation, biodegradable, biocompatible, promoting cell differentiation towards chondrogenetic and or osteogenetic phenotype, and dental. This is the scaffold that we used, and it is a 3D scaffold, the YALFAST, and it has all the requisites that we present before, and is a main degradation product of the hyaluronic acid, and is colloidal, so you can use it without any kind of device to attach it to the bone. And we tested the in vitro, this kind of scaffold in vitro. We did this paper last year, in vitro release and expansion of mesenchymal stem cells by hyaluronic acid scaffold used in combination with bone marrow. And we stated that the influence of the structure and composition of the scaffold is particularly relevant since it could provide favorable microenvironment for mesenchymal stem cell proliferation and chondrogenesis, not only in vitro but also in vivo. So, summing up what we said before, MICI is a 2-step surgery, high cost, no point effect regeneration, but has good result in the literature. Bone marrow derivative mesenchymal stem cell implant is a single step surgery, less expensive surgery. It has bony, it gives us bone regeneration, but we have not yet the results. In our case series, we treated the white lesion, more than 1 centimeter to 5 centimeter square centimeter, with 39 MICI 17 mesenchymal stem cells bone marrow derived implant, and 43 microfracture with YellowFast. And in the smallest one, we use only microfractures or osteochondral transplants. So, to have a comparison between the chondrocyte implantation and the mesenchymal stem cell implant, we collected the patient with this kind of inclusion criteria and exclusion criteria. The exclusion criteria were no arthritis, no skeletal malalignment, no ligament tear, no patellar instability, no kissing lesions. So we collected these two groups. The first group, 17 cases of chondrocyte implantation, and the second group, 15 cases of bone marrow derived mesenchymal stem cells and YellowFast implant. The two groups has the same mean age, the same gender difference, and the same defect location. The follow-up is a little more long for the first group because we started before. All we know, the chondrocyte implantation that we did with the same kind of hyaluronic acid scaffold. And for the protocol of the implant of mesenchymal stem cells, the first step is to collect, to aspirate the bone marrow from the iliac crest. We aspirate 60 millimeters for each patient with different injections, and we process the bone marrow to have a 7 milliliter concentrate bone marrow, and we use it on the patch, on the scaffold, with 3 milliliter per square centimeter. And then the preloaded scaffold can be implanted by arthroscopic technique. So we recognize the tear and we prepare the tear with a good bed, and then we implant in dry knee the scaffold, as you can see here. This is a video in which you can see how it's simple to repair a large defect. Doesn't work. A large defect in which you can find the large defect, then you have to prepare the bed correctly. We always do some microfracture, and then you have to remove the water, the fluid, and you can put very simply the scaffold into the knee, cover all the defect, and the surgery is ended. The postoperative rehabilitation key points are 24 hours immobilization, controlled passive motion for 4 weeks, joint loading after 6 weeks, back to sport, low impact 4 months, high impact 10 months after surgery. The follow-up evaluation was did with IKDC subjective preoperatively, 5 months postoperatively, and then 10 months. The technical score was did only after surgery, 10 months follow-up. The MRI assessment was did preoperatively, obviously, and then after 3, 6, 12, and 24 months from surgery. And we had the opportunity to collect 6 second look, 3 for the first group and 3 for the second group, with arthroscopy and biopsy, and then histology. So these are the clinical results of the first group. As in the literature, we have good results with an increase in the IKDC score postoperatively, more increase, more than 40 points after 5 months and after 10 months from the surgery. And we had a good technical score. And in the second group, we had reliable results with the same kind of clinical results, no pain, no problems for the patients, and good technical score after surgery. The MRI result give us a uniform postoperative pattern. With 3 months of subchondral, at 3 months we had subchondral bone edema, very important. 6 months without great diminishing of the edema, and 12 months with disappearance of the edema. But we found the coverage of the areas of chondropathy with integrity and restoration of the articular surface and joint lining. Important things, according with the results of Marcacci in 2005, we found in all the cases at 24 months a slight remodeling of subchondral bone. That probably means that the cartilage still is in remodeling process. And if we go to see the process of the remodeling of the bone and the cartilage in the two groups, we can see that the MRI are very similar. And in the two cases that we can collect after 3 years, we see that there is a little slight remodeling of the subchondral bone. That means probably that the cartilage is remodeling too, and probably cartilage such as a fracture can have in the time a remodeling towards a hyaline-like or hyaline cartilage. These are the second look, in which you can see that there is a perfect covering of the defect, microscopically at the arthroscopy, and then that the second look gives us a hyaline-like cartilage with chondrocytes in the lacunas. So in conclusion, on the basis of the results of this ongoing study, mesenchymal stem cells implantation via one-step regeneration procedure at present is a viable and lower-cost alternative compared to the two-step techniques. With confirmed long-term results, one-step approach could eventually replace autologous chondrocyte implantation. Furthermore, the use of mesenchymal stem cell implantation allows us to treat via one-step technique associated lesions, such as meniscal or ligamentous. Beware, in order to effective in joint tissue regeneration, mesenchymal stem cells seem to need a scaffold for improving bone marrow handling, favoring cell attachment and organization at the lesion site, stimulating mesenchymal stem cells differentiation into chondrocytes, and proper reorganization of the osteochondral compartment. Some KRP can add a supplement of growth factor to stimulate cell differentiation and optimize implant stability. The lack of a guide and containment in situ leads to the potential of these cells to a wide regeneration pattern. Thank you.
Thank you, Dr. Spoliti. Is there any question or, yes, please, your name and the country?
My name is Bogusław Sabdi from Poland.
Very welcome.
Thank you. Very nice work.
Thank you.
Congratulations. I have two technical questions. How do you achieve the dry setup in the joint while you including the biomaterials? And which tools do you use for reach the border, the perpendicular border of the healthy cartilage in the bed of defect?
To remove the cartilage and create a border.
To create a border in the...
Okay, usually I use some tools, to debride all the cartilage. Sometimes I use the shaver with a burr, and I usually dry the knee with aspiration, the normal aspiration devices that you use for the open surgery, and then I use how you call come chiami? Simple patch to remove the yes. I put the patch into the joint with the grasper, and I do the bed perfectly dry. Yeah.
Have you ever tried?
Like in open surgery, I do the same thing but from the old.
From the little
Yeah.
touch. But have you ever used the hyperpressure of the gas, inflation with gas? Like
No. In that case, I elevate the patella with a stitch, and then I work with a cannula.
Because I saw the Professor Maiotti wrong. They like to make it the same technique, but
No.
with the hyperpressure of the gas.
Yeah. I don't use
It's
gas.
very complicated. Thank you.
Thank you. Another question?
Yes, Daniel Kleiman from Chile. Which is your weight bearing protocol?
The weight bearing for the condylar defect, I use 6 months not weight bearing. Sorry, 6 weeks no wheel bearing.
6 weeks, no bearing at all.
Exactly, I used 4 weeks no wheel bearing at all, and then I started with small wheel bearing, 20% of the weight. Okay.
Thank you.
But the most important thing is the movement after surgery. You have to maintain the knee movement. That's the motion.
Okay, thank you. Your presentation was excellent. One-step surgery
Yeah.
with minimal invasive approach in a short time.
Yeah.
Thank you.
Thank you.
Dr. Szymanski, please, from Poland.
Can I have my presentation please uploaded?
It's uploaded. No, don't change. Do not change. It's uploaded. There it is. All right.
Thank you, Hadi.
Hello everyone, my name is Konrad Szymanski, I come from Poland, from Warsaw, and I'd like to share with you my experience with Hyalofast and bone marrow. So you probably heard this question many times, and what if I tell you that you don't need to answer that question? Would it be interesting for you? If I tell you that there's another technique that is also very successful for treatment of cartilage, would you be interested? Because we know that microfractures do not work for everyone. We heard about the osteophytes, we heard about the results after a couple of years. We know about the cell transplantation procedures. They are very effective, they are very good, but they are also quite expensive. And most of them, there are some which are one-step procedures, but most of them require two surgical events. So this brought my attention to biomaterial that has the properties to stimulate the cartilage repair in a knee and then also an ankle. And this is a one-step procedure, and you can perform it laparoscopically, and you can use microfractures, which is a standard procedure. And something what I would like to tell you now is to use the bone marrow. Instead of making microfractures, you bring exactly the same organ to the defect site. Why would you think about using hyaluronic acid? Because it plays an important role during the limb development. And actually, according to the research, this biomaterial can mimic the embryonic event in a defect site. So we can recapitulate the same events that are happening during the limb development. And these biomaterials has been studied by Dr. Kaplan, who founded the tissue engineering philosophy based on mesenchymal stem cells and hyaluronic acid. And I was fortunate some 12 years ago to study in his lab, and this is my PhD project. And I was simply taking the MSCs, mixing them with, loading them onto the hyaluronic scaffold, exactly the same as we are talking about today. And I was loading the cells in different concentrations. So my hypothesis was that if I put more cells, the better cartilage I'm going to have. So the results were not so clear for me. You can see at the lower bar, this rabbit made a good cartilage. The more cells, this is a standard procedure that Kaplan was using, was just soaking the cells into solution. And the implant into cells solution. This is 500,000, this is 1 million and 2 million. And you see that this rabbit, the more cell you put, the better cartilage was. But look, if you look at this one or this one, it doesn't look like this. So the conclusions I had 10 years ago was that probably there is high variability between different animals in MSC preparations. And probably this is something that depends on the quality. But when I look at it now, so I might answer the question, maybe it doesn't matter. Maybe it's just that the cells are making good cartilage or they're not making good cartilage. So maybe the number doesn't matter. So this brought my attention because we know that the MSCs are not actually the cells that are building, but those are cells who are regulating the process into the defect, inside the defect area, because those cells can stimulate, they can secrete the growth factors that can stimulate the tissue repair. And actually, we know that the bone marrow is not just the space that the cells are floating inside. It's also the hugely instructive organ that supports other cells. So I published in 2006 the results of transplanting the patient's own bone marrow into the periosteum, and it worked very well. But the problem was that the suturing of the periosteum was very difficult, and it was open procedure. So actually, Hyalofast is something that can hold the bone marrow inside the defect. So I'm going to show you some results of over 40 patients that I have operated with the longest follow-up of 2 years, and half of them had microfractures with Hyalofast, and the other group had the bone marrow with Hyalofast. So as you can see, this is a relatively small defect, and most of the patients had only one defect, and most of them were operated arthroscopically, and a couple of patients I didn't see them. It was not necessary to use the fibrin glue, but in most of cases I was using fibrin glue. And what were the concomitant procedures to those implantations? Of course, the first two were made to unload the defect, the repair site. Meniscal scaffold was used to recreate the shock absorber inside the knee, and of course ACL reconstructions to make the knee stable. So as you can see, most of my patients were patellofemoral joint